are a Francophone student. Why wouldn't you? Like, this is the whole point of hiring, of taking on Francophone medical students, is to try to answer our accountability mandates. There we go, for this population. And I went, what is going on? So I chatted with them, and they said, we don't have any training. I don't know the terminology. I don't know how to really help this population. We are trained in English. And I said, okay, something's got to change. And so we've done a few different things at the medical school, including some simulated clinical sessions where they kind of do a mock interview with patients in French. We also have terminology sessions, and now we're having this. So this is kind of the next step in our voyage together. So we want to see if we can broaden our impact. To get in the right frame of mind for today, because I'm going to be passing the word along to Patrick very shortly, what I'd like you guys all to do is just come on a little trip with me. If you are fluent in one of the languages that I choose, please just pick another language. But let's say to get in the right frame of mind here, let's all pretend that we are gone on a trip to Mexico. Now, if you're fluent in Spanish, say it's Italy. If you're fluent in both, let's say China. But I liked Mexico because that felt like a vacation that I would want to go on right about now. So let's say you're on a trip to Mexico and you get sick. You get sick, maybe you're coughing, maybe you've got some chest pain, but you are sick, you are worried, you're scared. So you go to the hospital, and the sum total of your Spanish, which is dos cervezas, por favor, is not getting you very far. Right? You maybe can muddle through enough of the language to maybe get through some of the things, but it's scary, you're stressed, and you can't help but feel that these people aren't going to understand what the heck you're talking about, even though you can pick up a little bit enough to kind of get the message across maybe. So use a lot of hand gestures and pointing, and maybe Google translates out. But that's your experience trying to get healthcare in a second language. Well, that's what our Francophones go through every single day when they access our healthcare system. And that's what we want to make sure that you guys are aware of. And we want to talk about tips and tricks on how to help them manage that system. And that's what brings us to today. So I'm going to pass along to Pat, but first of all, I'm going to leave you with this little quote that I saw from a patient that really resonated with me. Because one of the things that I hear about a lot from Anglophones is they're Francophone and they're in Northern Ontario. They all understand English. It's fine. And the quote is this: I might be able to live in English, but I feel my pain in French. And that's what these people are going through, and that's what we need to help them out with. So with this in mind, here's Patrick Timony. And when he's done, I will come back with a few real-world examples on some of the challenges and some of the things that we can do to help them out. Here you go, Pat.
Perfect. Thanks, Megan. And actually, as we're going through my presentation, I might ask Megan to chime in and give a little few examples from her side. And if ever she feels compelled to do so, she can stop me and give a few examples. We usually trade off as we go. So as I'm setting up my screen here, because I did prepare a presentation for you, what I'd really like to present myself is let you know that I am a research associate with the Center for Rural and Northern Health Research. And I've been conducting research on Francophone health and Francophone health issues for about 10 years now. So what I'm presenting is sort of a culmination of that 10 years of work. So some of the stuff is a little older, some is very, very new. And what I tried to do is try to find areas in our research where we found some of these cracks that Francophones might be falling into. So before we get started on the presentation, let's get started on the first interactive question. So if everyone clicks on that link and pulls up, the question was, do you offer French language services in your practice? Now, this is for those of you who are actually in practice. I understand there's a couple learners with us. For the learners, when you see questions like this, think of yourself, will I be offering French language services when I am in practice? So we'll give everyone a few moments to vote. So far, it's looking like the majority do offer French language services, which is excellent. This is what we want, what we hope to see. We're at now 25 votes. So
You know what? How can I access this easily? I mean, putting a link. You put in the link, short link a bit earlier, but it went too fast. It disappeared. So how can I do this?
At the very top of the screen that I'm showing here, we have this http://etc.ch. If you type that in,
it's directpool.com, and
actually the link is in the chat again, Carol.
It's in the chat.
Yeah, keep watching the chat. You'll see whenever information needs to be shared, it will be there.
Oh, okay, thank you.
Merci.
Okay, so now at this point we've got about 30 participants. So and the majority of you, it looks like 2/3, if not more, are offering services in French, and that's excellent. Particularly if some of those people that answered do not consider themselves Francophones, because there are a lot of things that you can do if you're not Francophone to offer services in French, and that's a little bit of the theme that we're going to be doing today, or speaking about today, is what are some of the strategies that you can use. So, with that in mind, as I mentioned, I do work for the Center of Rural and Northern Health Research. And let's get to the second question that I had for you. Again, this is a question for particularly providers, but you could think about how many Francophones are in your community if not. But for those of you who are in practice, what would you say is the percentage of your patients who speak French? So we have a few votes coming in. One person says 90 to 100. I'm assuming that two people now, these are people that are working in a Francophone health center setting where all their patients are French. A lot of people, 4 are saying between 21 and 30, which is probably pretty accurate to the community level of Francophones, within the community. So I'm saying 30 to 40, if you're saying 0 to 10. I asked this question, and you guys can keep voting as we continue on here. I asked this question because I had the experience conducting an interview with a physician a couple of years ago, where we asked the physician, and we were in sort of an open room. We asked the physician, what is the percentage of patients that you speak French? And the physician told us, I don't know, it's probably 5 to 10%. And the receptionist was behind us and she could hear us talking, and she said, what? No, it's like 40% of your patients. And so we really realized that sometimes people don't know what the percentage of their clients speak French. And I just want you to think about that. Do you know that this is the percentage of your clients that speak French, or is this the percentage of clients that have told you that they speak French? So how do you know this number is kind of important. And it's one of the things that we want to, one of the strategies that we want to talk about today is, have you ever asked your patient, what language do you prefer? And that first step of communication is vitally important. So we'll now get back to the presentation. So speaking of Francophones in Ontario, and a lot of the work that I've done and a lot of the data that I will present, we'll look at the data in this way. So Northern Ontario, our definition of Northern Ontario is the blue portion, goes up from Parry Sound, or stops at around Parry Sound. The green would be Southern Ontario. The dark colors are, the checkerboard patterns in this map would be urban communities. And then the darker colors represent strong French communities, that is, communities where at least 25% of the population speaks French. Moderate French communities, between 10 and 24.9% of the population speaks French. And then we have weak or no French communities, that's where less than 10% of the population or 0% of the population speaks French. And it's very clear looking at this map that Northeastern Ontario has a large proportion of Francophones living in it. That's not to say that there's not pockets of Francophones elsewhere. They just make up a smaller proportion of the total population. And that's also pretty clear when we look at these numbers of the percentage of Francophones by region. So in Ontario, we're talking about 4.7%, 5%-ish of the population that is Francophone. Northeastern Ontario, we're at 22.6%. So if you're practicing in the Northeast, it's likely that you will come across Francophone patients at some point, probably on a daily basis. Another thing that I think is interesting to note is here, these are just kind of graphs showing the number of Francophones in Ontario from 1986 to 2016. And we see that in green, the total number of Francophones is growing. But the issue is the Francophone population is not growing at the same rate as the entire population of Ontario. And so the proportion of Francophones, or the percentage of Francophones in Ontario, is actually getting smaller as the number gets higher. So that's important to know, because just because there are fewer or a smaller percentage of Francophones in our communities doesn't mean that there's fewer Francophones. We're still growing in numbers, but not at the same rate. So now we go on to our third question. And actually, before I go to this, I'll post the third question. And I've actually made it visual here. Whoop. Oh, no, I guess I didn't. Okay, sorry. I'll post it. So the question is, which of the following statements are false when compared to the general population? Francophone tends to be older, less educated, more likely to be living in poverty, more likely to live in a rural area. And then, I'm sorry, one of these is cut off. That one says more likely to suffer from multiple chronic conditions, more likely to smoke, or more likely to consume alcohol, or more likely to be overweight. And I think I just lost my screen. I'll put it back up. Okay. Can someone confirm that they still see my screen?
No, it's only
No.
you.
Wait.
Okay.
Oh no.
So, keep up with Zoom.
Just you.
Okay, and now it's back up?
Yeah, it's back.
Yep.
Okay, perfect. Okay, so you can give multiple answers here because the question is which of the following, not it's not which one, it's statements, plural, so there could be more than one. And I see a lot of people are saying the less educated. There's quite a bit of answers across the board. So I'll give a little bit more time. I'll wait till we get to about 25 participants, and then I'll move on to the actual answer to this question. So maybe I won't wait till 25, around 21, 22 now. So the majority of you seem to think that they're less educated, and then a few people are saying that it's false, that they're more likely to be overweight. But we do see a number of answers across the board. I will tell you that there are 2 false statements here. The rest are all true. And so the education is growing in numbers, so that's good, because that's the reality, or one of the realities. So this information comes from multiple sources. Some comes from the 2016 census, some comes from a report from 2013. But what we're seeing is that, yes, Francophones still tend to be older. So the percentage of Francophones that are 65 and older is 19.5% versus 16% of the general population. But they are not less educated. So if we look at those that have a post-secondary education or greater, it's 68.1% of Francophones versus 65.2%. So there are fewer Francophones that have no education at all, or that have only a high school education. But when we look at those that have anything post-secondary, there's actually more of them. So they are, in general, or in overall, they tend to be more educated than the general population. The living in poverty one was kind of a trick question, because this flipped in 2016. I think this was the first time that Francophones on average had a higher income than the general population. So I looked here at those that had an annual income of greater than, or 20,000 or greater, or sorry, greater than $20,000 a year. And for Francophones, or sorry, less than, so the poverty, Francophones is 32.2% that make less than 20,000 a year. The general population, it's 35.4%. And then what we notice is after the $30,000 mark, every strat after, every grouping of income after, Francophones make more money than the general population. So, and that, I think that's a change that was new in 2016. Up until that point, Francophones made slightly less. And then all the rest, Francophones are more likely to live in a rural region, 16% versus 9%. They are more likely to suffer from multiple chronic conditions, so 20% versus 17%. They are more likely to be smokers, 72% versus 65%. More likely to consume alcohol, 81 versus 79. So not huge differences there, but still. And they are more likely to be overweight. So 18.3% have BMI over 30 versus 16.6%. Here. So now that's a little bit about Francophones and about the realities of Francophone. Now I want to talk a little bit about the research that I've done. And the way that I've organized sort of my research is by identifying different cracks that Francophones are falling into or potentially are falling into. And the first crack is access. In 2005, a report by the Fédération des communautés francophones et acadiennes du Canada said that access to healthcare services in French for Franco-Ontarians is severely lacking in hospital services, community health centers, medical clinics, and home care, which are the 4 sectors which cover most healthcare services available in Ontario. This was in 2005, and things have not changed greatly since 2005. There may have been some improvements in some areas, but the work that we've done, we asked ourselves, where are French-speaking providers located in Ontario? And we asked that both at 2 levels, at the physician level, using data from the College of Physicians and Surgeons of Ontario. And we also asked about pharmacists, and that's work that I'm currently working on, is looking at the distribution of pharmacists in Ontario. And this is with data from the Ontario College of Pharmacists. So what we did is we looked at the geographic distribution, where are they in the province, and we created ratios of French-speaking physicians or pharmacists per 1,000 Francophones. What we noticed is that, first off, 15% of physicians self-identified as being competent enough to practice in French, and 7.5% of pharmacists said they were competent enough to practice in French, which is actually pretty good when we consider 5% of Ontarians are Francophone. So this 15% and 7.5% should be enough to take care of that 5% of Francophones. There's more percentage-wise pharmacists and physicians that speak French than there are French people in the province. Percentage of total is what I'm saying. The problem is where they are located. So both physicians in blue and pharmacists in green had a tendency to work in urban southern communities. So for physicians, we have 4.32 physicians for every 1,000 Francophone, and we have 2.4 French-speaking pharmacists for every 1,000 Francophone in the urban south. So in areas like Toronto, like Ottawa even. When we look at Northern Ontario, we're at 1.5 for physicians and 1.14, 1.12, regardless of whether we're looking in rural or urban community. So that was one issue, is that the majority of French-speaking physicians were located in urban Southern Ontario. But that doesn't necessarily mean that they're not practicing with French or practicing in a community with French people in them. So then we looked at the same ratios, but by the degree of Francophonie, those strong, moderate, and weak French communities. And what we found is the weak French communities always had the best ratios, both for physicians and pharmacists. And in both cases, as we see more Francophones in the community, there are fewer French-speaking providers in that community. So this access is one of the first cracks. The providers, both physicians and pharmacists in this case, that can offer services in French are not necessarily practicing in communities where there are the largest proportion of Francophones. So that leaves many communities with many Francophones comparatively underserved. The next crack that I want to look at, or that we want to talk about, is that of workload. And this is work that we did with French-speaking physicians only. But we asked ourselves, and actually before we do that, we'll get on to the next survey question, which is, who do you think has the heaviest workload? And I'll actually put it up here. This is the one because it was very difficult to show. So who would you think has the heaviest workload? A French-speaking physician in a strong French community in Northern Ontario. So I gave an example of A, let's say in Sudbury. An English-speaking physician in a strong French community in Southern Ontario. So I said the southeastern area, Champlain area, or actually a little bit even east of Ottawa. A French-speaking physician in a weak French community in Southern Ontario. So let's say a Toronto or a Mississauga. Or an English-speaking physician in a weak French community in Northern Ontario. So let's say Thunder Bay. So who do you think has the heaviest workload? Who do you think works most hours, sees more patients? Now we'll see what people are voting. And out of the first 10 votes, people are leaning towards French-speaking physicians in strong French communities in Northern Ontario. And at 16 votes, it's the majority of you that are thinking that. Now, a few people are chiming in with English-speaking physicians in strong French and French-speaking physicians in weak French communities. No one thinks it's an English-speaking physician in a weak French community in Northern Ontario. So now at 20 participants, the majority of you are thinking it is a French-speaking physician in a strong French community. Now 13. I hope it's not because you've seen me speak before or read my work, but that's pretty much what we found. So what we asked ourselves is, what are the practice characteristics of French-speaking physicians? And we often hear anecdotally that if you speak French, you're in high demand. If you can offer services in French, every Francophone person will come out of the woodwork trying to get services from you. So our hypothesis was that French-speaking physicians in strong French communities would have a heavier workload in terms of the number of hours they work per week and the number of patients they see per week. And that's essentially what we found. So when we look at the hours worked per week, we see that in weak French communities and moderate French communities, non-French speaking physicians have a tendency to work more hours. But in strong French communities, French-speaking physicians have a tendency to work more hours. Also, in French-speaking communities, all physicians work more hours, so there is a heavier workload in those communities. But this is really only a difference of 1 hour per week, not even. So it's not a huge difference, but when we look at it at a regional level, we notice that in all regions, whether it's rural, not so much in urban, but rural and Southern Ontario, non-French speaking physicians work more hours. But in Northern Ontario, French-speaking physicians work about 5 hours more per week than non-French speaking physicians. When we look at the same sort of, or we do the same sort of exercise, but we look at the number of patients they see per week, we notice a lot of the same. Weak French communities and moderate French communities, those non-French speaking physicians will see more patients. In strong French communities, it is the French-speaking physician that sees more patients. Again, in general, strong French-speaking communities have a tendency to have a heavier workload overall. But again, when we look at it by region, we see that on average, French-speaking physicians do tend to see more patients, but particularly in Northern Ontario, where they see about 20 more patients per week. So when I ask the question, who has the heaviest workload, it would be one of these A communities, a physician who is in a strong French community in Northern Ontario will have a tendency to see 5 more patients per week and work 20 more hours per week. That's the equivalent of half a day's worth of patients when we look at the average physician, and 1 day's worth of work. 20 hours is the average. On average, physicians work about 20 hours, 20 patients per day. That's the equivalent of 1 day's patient load. And they have a tendency to work 10 hours per day. So 5 hours is like half a day more a week. So if you are a French-speaking physician working in a strong French community, you have a heavier workload. Now, why do I say that that's one of those cracks that Francophones are falling into? Because as we saw earlier, there are fewer French-speaking physicians in those communities. And so those that are in the communities have a heavier workload, have a greater risk of burning out. And maybe it's one of the reasons that some physicians won't report what language they speak because they're scared that they're going to get inundated by French-speaking patients. So the next crack that we'd like to identify is that of the barriers to serving Francophone patients. Now, we conducted a number of interviews with French-speaking and English-speaking providers, and we asked them what are some of the barriers they experience when they have a French patient. And they mentioned things like language discordance. If you do not speak the same language as your patient, that is a barrier. There are things we can do to overcome them, but that barrier is going to exist. That's a reality. Other barriers are the characteristics of the Francophone patient. So a lot of those things that we noticed earlier, that I mentioned earlier, like the fact that they tend to be older, they have more chronic conditions, they actually have more cardiovascular problems, they eat fewer fruits and vegetables, more likely to be smokers. That's on an average provincial level, but physicians were also recognizing that their French patients had the same sort of characteristics, that they were sometimes a harder group to serve because they had multiple conditions. Another barrier that was mentioned was the dominance of English in medicine. People said that, well, I did my education in English, I received all my correspondences in English, I talked to all of my colleagues in English. English is the language of medicine. So it's just natural that when I see my patients, I just have this natural tendency to talk English when I'm talking medicine. And that's hard to break, and that's understandably hard to break. And that's why we conduct sessions like this, to try and sensitize people to the fact that you don't have to speak French in medicine. It's important actually to speak French to your French clients if you can. Another barrier is the lack of French-speaking medical personnel. It is a great strategy to try and hire French staff. That doesn't mean that that's going to work out. The most qualified person who can speak French likely is working somewhere else in a hospital somewhere else or what have you. A number of physicians told us that we tried very hard to find bilingual staff, but it is so hard to keep them because once we found them, the hospital in the urban community is offering way more money than we can, and we lose them to that hospital. Or there is a much smaller pool of French staff that we can even pull from. So we hire as many as we can, but we can't always find that French personnel. And that is another reality that is obviously difficult to overcome, but there are things that we have to work on. And then the last sort of barrier is one that we called linguistic insensitivities. So in this case, French-speaking providers told us things like, well, I know my clients well enough to know who wants French and who wants English. And so I just speak French to my French clients and I speak in English to my English client, which is fine, which is great. The only problem is a lot of French clients, a lot of French patients are not going to say, no, I want my services in French. If the conversation starts in English and you never ask them what their language of preference is, they're not going to tell you. And so you might be assuming that you have French patients that prefer English, or you might, be assuming that you have patients that prefer English when in reality, they would be more comfortable in French. And then from the English-speaking perspective, English-speaking physicians told us things like Dr. Cusack mentioned earlier that everyone's so bilingual, it makes no sense for me to speak French. And that's a hard one because it is true that a lot of Francophones in Ontario can speak French. They have what's known as functional French. They can function. They can order coffee in French, go to the restaurant and order something. They can have a little conversation about the weather and what they're planning to do on the weekend in English. However, that doesn't mean that they can talk about their medical conditions in French, particularly not when we're in English, particularly not when we're talking about mental health needs. People can't describe what they're feeling in English. They don't have the terminology to describe their feelings in English. So although they can speak some English, that doesn't mean that they are fluently bilingual when it comes to their health in English. So we talked a little bit about the provider experience. Another crack is the patient experience. So we also conducted interviews, focus groups with French-speaking patients. And these patients either had a French-speaking physician or they had a non-French-speaking physician. And we asked them, what is your experience with accessing services from your physician? And those that can speak French had a very positive experience. There was always positive emotions, like they feel comfortable, they feel like the service is accessible, they feel safe, they feel like they're better able to take care of themselves when they speak to their providers in French. Non-French speaking physicians or patients who had a non-French speaking physicians had overwhelmingly negative experiences. They talked about how they weren't comfortable. They felt the service was inaccessible, that they didn't feel safe and that they were just not able to take care of themselves after. They didn't know what to do after. We also asked these patients to identify different critical moments in their path during a visit to their physician's office. And they say that even before, when they're preparing their appointment, if they know they're not going to be able to speak French, there's anxiety that comes out, and they prepare all their questions and they translate all their questions, and they're so scared that they're not going to be able to ask the right question, or they'll forget how to say something. So there's anxiety before even entering the office. Once they get to the office, if they're not greeted in French, they're not welcome in French, they just don't feel comfortable. If they're sitting in the waiting room and everything around them is in English, again, they don't feel like this is a place for them. If they receive care from a nurse practitioner or another healthcare provider and it's not in French, all those emotions come up again. They don't feel safe. They don't feel like they're properly being understood. There's waiting in the waiting room that they might not feel comfortable. And then there's a whole cyclical process when they actually see the physician, where they might explain the reason for their visit. They might have a discussion about their health. They might receive test results or a diagnosis. They'll ask questions. They'll try and understand the physician, and then they'll receive some sort of treatment. And then these things are interchangeable and it's cyclical. But all of that time, if they can't speak in French to the physician, there's a lot of negative experiences and a lot of negative emotions. Whereas when they can speak French, that is a lot more natural of a conversation and they feel much more comfortable. So another study that we did actually surveyed patients and we asked them, we actually gave them a patient satisfaction survey, and we knew whether or not they spoke French or English with their physicians. We asked them, do you speak French? Do you speak English with your physicians? We want to know, does patient satisfaction depend on a combination of the language of preference of the patient and whether or not they receive languages, French language services from their physician? And what we noticed is in red in the graph, if the patient told us that they prefer to speak in English, it didn't matter whether or not they were receiving services in French or not, they were equally satisfied. It was no difference at all. However, if they told us that they prefer French and they regularly receive services in French, they were statistically more satisfied with their care than if they prefer French and they rarely or never receive services in French. So patient satisfaction does depend on the language of the service that they're receiving. And this is important because patient satisfaction is really the only metric that patients can use to measure or to tell you about the quality of care. Their impression of satisfaction is a reflection of the quality of care they're receiving. So those that are more satisfied are usually receiving a higher quality service. So that's important. If you really want your patients to be satisfied, offering services available to them in French will go a long way to helping them be more satisfied with their care. So the last sort of crack I wanted to talk about was this gap in beliefs. I mentioned it before, I'll mention it again. After talking to patients, time and time again, they say things like, je suis beaucoup plus à l'aise si je peux m'exprimer en français, même si je peux parler un assez bon anglais. So even though I can speak English, I'm way more comfortable in French. And physicians told us often that patients are so bilingual, it makes no sense for me to speak in French. And we noticed there wasn't that communication between the two. Patients are not going to tell you what their language of preference is. So if you don't ask them, you'll never know. And it's very possible that there will be patients who prefer French, but are never receiving services or never being offered services in French. So a little bit about the importance of communication. We know communication is essential for quality of care. If you're providing primary care, it's the communication is the primary tool by which health information is exchanged. Unless you're doing a surgery, usually you have to speak to your patient in order to understand what their healthcare needs are and what their problem is. Communication is vitally important for quality of care, and quality of care depends on communication. It's recognized as one of the roles of a medical expert in the CanMeds framework. In order to be a medical expert, you have to be a good communicator. So a little bit about patient safety. We'll often hear providers tell us that, well, I don't feel comfortable offering services in French or speaking French if I can't speak a good French because I'm worried that I'm going to make a medical error when I speak in French if I don't feel like I'm competent enough to do it. But patient safety is a lot more than just not making medical errors. It also means that you're not reaching a wrong diagnosis. And that's there's so many examples, and actually that's the name of our presentation. J'ai mal au cœur is a great example of that, where a French patient will come in and say j'ai mal au cœur. A non-French speaking provider will interpret that as, oh no, you have heart problems, so you need to go see a cardiologist. When in reality, all the patient is saying is I have indigestion. So reaching a wrong diagnosis is possible when there's a lack of communication. It's also, you also want to avoid exposing the patient to unnecessary risks. And I'm sure Dr. Cusack has a lot of examples of that. But even if we just look at the literature, there's a tendency when there's a lack of communication, there's a tendency for the provider to be over medicating their patient. They offer more medication. So because they can't communicate, they can't offer a behavioral type of intervention. Therefore, they offer a they offer medicine. They medicate the patient instead of trying to change their behavior because they can't communicate. And that would put the patient at undue or unnecessary risk. And finally, it also means that you allow the patient to provide informed consent. And I would argue that informed consent is an issue with all consent forms, whether they're written in French or English. They're not always written in an accessible language. So if you really want the patient to understand, you have to speak to them in a language that they understand. And when I say that, I don't mean speaking in French to Francophones as much as I mean speaking in using terms that they understand, using a common language, plain language, so that they understand what you're talking about. And that could be a mix of French and English, particularly in Northern Ontario, where a lot of franglais does exist. So from the literature, a little bit about the importance of communication. I'll run through these fairly quickly, but good communication usually leads to a greater understanding of medical information. Patients are better able to cope with their disease. They have higher quality of care. They have better health outcomes, a greater sense of well-being, better medication adherence, and better patient return rates. Whereas poor communication is linked to things like it's a barrier to health education. There's less comprehension and compliance with the provider's recommendations. There's more adverse medication reactions, more hospital admission, more prescribed medication, lower rates of optimal pain medication, and less adequate management of chronic conditions overall. So these are a lot of examples in the literature of where good communication leads to better care and poor communication leads to often worse care or worse outcomes. And it's important to note, I'm not saying Francophone or French services versus non-French services. We're saying communication. It is possible to offer good communication even if you don't speak the same language as your patient. And that's what we're going to get into in the next part here. How do we bridge that gap? How do we offer services to those French patients? So the next two questions I had for you is, so first, do you consider yourself competent enough to conduct your practice in French? Do you consider yourself as a competent, to be competent enough to practice in French? So at 15 votes, the yeses are taking it. So most of you do consider yourselves competent, but a number of you say you don't feel competent in providing services or practicing in French. And at 20 votes, it's about a third more that say that they do, or actually it's more like half more. So the next question I have is, if you, especially for those who said no, if you don't feel like you're competent enough to practice in French, can you speak or understand any French at any level? And I saw a little in the chat there, someone said that they don't actually offer services. Well, that is true. I prepared the survey for healthcare providers. If you don't offer a service, you're not currently a healthcare provider. Just think to yourself is, would you offer services? Or do you think, this one everyone can answer? But yeah, can you offer any French at all or speak any French at all? And here it's the vast majority. Almost everyone can speak a few words in French. Which is great, because that's a good start. That's the starting point for becoming a French healthcare provider. So at this, we'll move on. So how do we bridge that gap? How do we offer services in French, or how do we better serve our French client? There's a number of strategies. First, we can try and train future French-speaking providers. And this is really a long-term strategy. This is not going to help us today or tomorrow. This will help us in 5, 10 years from now. And that's what NOSM, with their social accountability mandate, that's what NOSM is trying to do. They're trying to identify French students and train them in an environment where they'll be exposed to French education or French practice, where they do sessions like these ones and other standardized patient sessions in French, so that when they do become, where they are in practice, they will be able to offer services in French or offer better services to French patients. But like I said, that's a long-term strategy. There's also targeted recruitment and retention strategies, which is sort of a medium term. And I say medium because if we can recruit a French provider, that's an immediate strategy, yes, but we see that incentives are often ineffective at retaining providers. As soon as the incentive leaves, the provider usually leaves with it. And so we end up with this revolving door phenomenon where a community might be successful in recruiting a French provider, but then as soon as the incentive leaves, the provider goes off to another community, and then they're back on their search for looking for someone. So it's a medium term, and it's not a long-term strategy. They won't stay there forever, or at least they haven't been. The third strategy that we're suggesting is to equip current providers with the tools to better serve their Francophone patients. That is an immediate and long-lasting strategy. That making sure that everyone who is working in these strong French communities is capable to serve French patients to the best of their ability. And that's what we're doing with sessions like today, is sensitizing people to the need for French services, but also providing some strategies for things that you can do. And one of those strategies is the active offer of French language services. Now, I hope at this point that most of you have heard of the active offer of French language services, but for those who haven't, the active offer is a proactive offer of French language services which are available at all times. It shouldn't only be once a week or on certain days. The French service should be clearly communicated. Everyone that enters the door should be told that if you want services in French, here's what we can offer. It should be visible. It should be on your signage. It should be out in the open that you can offer services in French, or that French services are offered in your organization. It should be easily accessible, and it should be equivalent in quality to the services offered in English. Now, what are some of your responsibilities as a healthcare professional? Now, for those of you who aren't healthcare professionals, bear with me, but for those who either are or will be, your responsibility will be to proactively welcome French clients in French. Now, that might not be you doing it. It might be making sure that whoever is at reception is doing it, or whoever is welcoming patients is proactively welcoming patients in both languages, in French and English. It's your responsibility to understand the need of your Francophone clients. What are their linguistic needs? What are their health needs? What are their linguistic preferences when it comes to healthcare? Have that conversation. What language do you prefer? And then if I can't offer services in French at that level, well, what can I do? Can we have an interpreter? Can we make sure that we have French documents for you to look at? What are some of the strategies that we can use? But you need that conversation up front so that your client knows that that's something that's important to you, and they feel comforted in the fact that although you might not be able to speak a fluent French, that you're at least making an effort to offer services in French. The next responsibility is to provide the client with the necessary care, or refer them to resources that are better able to provide such care. If you really can't understand your patient, maybe they need to see someone else. And that's not always possible, but when it is important to try and do it. One of your responsibilities is to take on a leadership role by promoting the active offer. You don't need to speak French to know that it's important, and to promote it's important within your organization. And then finally, it's your responsibility to ensure quality of care for and the safety of all the patients you serve. And that means making sure that French patients don't fall in the cracks. So with that, I'd like to ask Dr. Cusack, do you have any insight as to these responsibilities, and how do you experience these within your practice? Did you want to give your 2 cents on this slide?
Absolutely. So, I mean, I have been, as everybody knows, the clinical physician lead for what, 7-8 years now, and we've done this presentation a few times, and it always shocks everybody to hear that I have a really hard time remembering to do that active offer to my patients. Now, it seems so easy. What's the big deal? But you know what? When your focus is on the health of the patient, and you do have a sense of them. I mean, I'm in family practice, so I've got my patient population that I know fairly well, and it's just an easy crack to fall into, to assume that you know what people's preferences are, either based on your own recollection, maybe it's even false, you know, but it behooves us all to do that bilingual welcome to every patient. Hello, bonjour, you know, how are you today? Comment ça va? At meet and greets, I'm actually pretty good at meet and greets. You know, hello, bonjour, my name is Dr. Cusack. Est-ce que vous préférez en français or do you prefer in English? You know, to just do that introduction, and to not forget that one of the most universal characteristics of a Franco-Ontarian, especially, a Northern Franco-Ontarian, is this: we all think our French is crap. We have no confidence in it, and I cannot even tell you the amount of times that I've had patients say, no, I would rather speak in English, thank you very much. And I'll go, oh, I'm thinking to myself, like, oh, Pookie, right? Like, you're falling into that same crack again. So I'll just say, you know what? How about this? I said, moi, je suis complètement bilingue. We can speak back and forth en bon franglais, just like good franco-ontarien. And you let me know, you speak whatever language que tu veux, là, and we'll just go back and forth. Cool? And then the patient, you can see them, they just go, oh, awesome. So if the thought or the feeling or the emotion or the symptom comes forward in French, go for it. If they would rather speak in English, they're not feeling stuck with this stuffy Francophone doctor who can speak in French. They're not stuck with the Francophone piece. So really the take-home message of all of this is ask, advocate. If you see somebody falling through the cracks, don't let that happen. You guys are the change that we want to be, right? This is our chance to make a difference. So, that would be my 2 cents in terms of the real world.
Yeah, perfect. And what's great is that's Dr. Cusack's sort of sense of her responsibilities as a Francophone. It's important to note that on this slide, at no point are any of these responsibilities unique to Francophones. Everyone can do all of these things because it is ask and then have the conversation of where can we meet in the middle, and then advocate. You don't have to speak French to advocate, and that could be one of the strongest things you do, is making sure that there are more French services within your practice or within your organization. So the next thing I wanted to just show quickly is that survey I mentioned earlier, where we looked at patient satisfaction and whether or not they're receiving services in French. We also looked at patient satisfaction, and we had part of the survey a question or a series of questions on the active offer of French language services. And so we conducted a correlation to see if patients were more satisfied when they received French language services, or an active offer when they were actively receiving French services. And what we found was for Anglophones, there was no correlation at all. It didn't matter whether or not they were receiving French services. They were equally satisfied regardless. We don't do the active offer for the Anglophones necessarily. We do the active offer for the linguistic minorities, equally French as any other language. If you ask the patient, what is your language of preference, and they say anything other than French or English, well, that at least tells you, okay, this are the particularities of this person, and what can I do to better serve that patient in whatever language that they're most comfortable in. So the active offer is not for the English population who already understands English very well. It's for the linguistic minority population. And what we found was that Francophones were statistically more satisfied, or there was a statistically strong correlation between patient satisfaction and active offer, such that when the patient recognizes they receive an active offer, they were more satisfied than when they don't recognize that they're receiving an active offer. Not only that, but when we did a multiple regression, we saw that active offer scores alone were a significant predictor of satisfaction, and that active offer explained 23% of the differences we saw in satisfaction. So all this to say, if you want to improve patient satisfaction in your practice, try improving your active offer. And French patients will notice it. They do take notice, and it does go a long way to making them feel more comfortable and making them more satisfied with the care that you're receiving. So I'm just going to end on a few strategies. I talked earlier on about how we did interviews with physicians, and we asked about some of the barriers. We also asked them, what are some of the strategies? And now that hashtag Anglophone, hashtag Franco, hashtag all, these are some of the things that were talked about a couple of years ago when we did this interview. So English-speaking physicians told us things like using appropriate translators and interpreters. When I say appropriate, I don't mean sometimes you don't have a choice and you have to go to a family member. Family members should be avoided because oftentimes the patient doesn't want to tell their family member what they're going through. The family member might not interpret correctly, or they might want to withhold information from the patient to not worry them too much. So there's always, with a family member, it's never going to be a perfect translation. There's always going to be some sort of interpretation of what the family member wants the patient to know and what the patient wants the family member to know. So appropriate translators are people that are only translators. They said things like being sensitive to the patient's language preferences. Even though I can't speak French, I can ask them what are their preferences, and then I can figure out strategies to better serve that patient in the language that they want. And like Dr. Cusack said earlier, a lot of Francophone patients don't want to speak a perfect French. They want the franglais. They want half of it to be in English, but a few words to be in French. that's perfect. That means those are words I understand. And as soon as you throw in some words I understand, I feel way more comfortable. Like you're trying to offer services to me, not at me. And then to go along with that, learn basic French. Even if it's a few words, even if every time your French client comes in, you're able to ask them about how their weekend was, that goes a long way. And French patients are never going to be insulted if you don't say the right word in French. You could tell your French patient that, you know, I'd like to practice my French. Is it okay if we have a little bit of a conversation in French? No one's going to say, no, I don't want that at all. They're all going to be happy that you're asking for their help or something. So learning basic French and using it with your patients goes a long way in making them feel more comfortable. Francophone physicians told us things like using flexible dialect. Don't get caught up on the legal medical words. You don't have to say the proper French word. You have to say a word that the patient understands. And sometimes that's half French, half English. It depends on what the patient understands. And then ensuring French language medical training. All too often, Francophone physicians told us that we just don't have the opportunity to do any additional training in French. So whenever that training is available, like things like today, if it's available, try and do it, because it does, not only does it remind you of the importance of French, but sometimes you'll learn new strategies. Even though you may know all of the strategies we talked about today, it's likely that you're not doing all of these things all the time. And so participating in things like this just reinforces that, yes, this is something that I should be doing more often. And then a few things that everyone can do. First, whenever possible, hiring bilingual staff. That's key, making sure that people that can speak French are working for you and that they are using their French when they're working. The second is making sure there's some French language continuity of care. If you have to refer your patient out to a specialist or to a community resource, make the effort to try and ask the patient, what language do you prefer to receive this service, and try and find someone. It is additional work, but it's way better to spend that extra 10 minutes to look for a French service than it is to send the patient to a service that will make an error and then send your patient to the ER because they didn't understand what they were supposed to do, or they didn't properly understand the patient, or they did an additional surgery that they shouldn't have, that I'm sure Dr. Cusack will give us an example of very soon. Third, ask the language of preference. Everyone can ask the patient what language do they prefer. Ask, that is the message. And then for all of these are sort of active offer strategies, but practice the active offer. Make sure that signs are visible. Make sure that we're proactively offering services in French. A change to some, it's a change in your habits, but to make it a habit. Make it a habit to ask everyone what they prefer, and then try to offer services in the languages they prefer. So with that, I'll let Dr. Cusack talk about some of the other things that she's experienced.
Awesome.
Megan, est-ce que l'écran?
Non, c'est correct, ça. Give something for people to look at. Yeah, so just to kind of continue the points from Pat, what I can bring to the table is basically somewhat reiterating some of the points, but I can actually bring it back to just highlighting the fact that this really is an issue. Again, I feel like most Anglophones, because I've had the conversations before, saying they're all okay, they can figure it out. This is kind of the lack of cultural sensitivity or linguistic sensitivity that I see on a regular basis, that I'm sure if for the Francophones, we've all seen time and time again. But the reality is this, is that 20% of Francophones will actually delay seeking healthcare because they are so stressed at the thought of the experience that will greet them when they finally do access care. 20% of Francophones, right? That is absolutely significant. There's no question about that. What have I seen? Number one, or why is that happening, I should say? Number one, there is a patient perception of prolonged and or inadequate health assessment. So the most classic example, and what this presentation really is based on, is that comment, j'ai mal au coeur. All Francophones know it. All Francophones see it as the crack that it is, but Anglophones do not always know it, especially not Anglophones in a really small Francophone minority situation. And there's actually a study out of Winnipeg, and I couldn't find it to share you the numbers, but a study came out of Winnipeg that showed that just by changing the triage nurse in the emergency department, they were able to save millions of dollars at a Winnipeg hospital because people stopped ordering cardiac packs on every single patient coming in saying, j'ai mal au coeur. So cardiac pack, for those that don't know, is kind of this package of blood work and tests that are done to work the patient up even before the doctor sees them. So by just having that key position, which is triage nurse and emerge, be a bilingual position, we were able to save patients delayed testing, because you know that they're coming in saying j'ai mal au coeur. They're not getting the appropriate abdominal examinations until somebody who is able to figure out what the heck's going on orders them. So they've had the cardiac pack, wasted money. Now they're delaying actual workup of the actual problem in question until somebody figures it out. And if we're really lucky, maybe that'll be the doctor, or maybe that'll be one of the nurses who goes, why the heck was this ordered? If we're lucky, right? So wasted money, delayed diagnosis, 110%. Misdiagnosis, right? Something that I actually didn't know, because one of the questions that came up through one of our sessions was, well, Dr. Cusack, if Francophones say j'ai mal au coeur when they're feeling nauseous and indigestion and their tummy hurts, well, what do they say when their chest hurts? And I go, that's valid, I don't know. So I actually asked my nurse at the time, my secretary at the time, who came from New Liskeard, so very, very, very Francophone community there. And I said, what do you guys call chest pain? So she asked her dad, and her dad came back and said, j'ai mal à l'estomac, which any Francophone will tell you means my stomach hurts. So it's one thing to delay diagnosis and treatment and workup of indigestion by doing a cardiac pack. It is a very different thing to delay diagnosis of chest pain by doing an abdominal pack. And again, studies will show time and time again, patient reports will show you time and time again that heart attacks, myocardial infarctions, pulmonary embolisms are being missed because either the patient themselves or their family members accompanying them are saying, elle a dit, elle avait mal à l'estomac. What does that mean, sir? Her stomach, it hurt, right? So, I mean, in my family, we would have said, j'ai mal à la poitrine, et cetera, but there are pockets of communities where you're seeing different things. So again, you need to know, you need to be able to speak to the language. Now again, communication. Let's say I've had somebody say, okay, well, I'm Francophone and I would never have recognized that. I go, I realize that. And like I said, I didn't know until I asked my secretary. But if I saw somebody doing this, saying, oh, j'ai mal à l'estomac, I'd say, monsieur, vous me dites que vous avez mal à l'estomac, mais est-ce que vous avez mal ici, vraiment? Est-ce que vous avez vraiment mal ici? Est-ce que vous avez mal à la poitrine? I see that you're saying, my stomach hurts, but I'm going to go that step further, make sure that communication is understood. And just to clarify, is your pain up here in your chest or more really in your stomach? Communication, right? Poor understanding of diagnosis and treatment. This is one that I can speak to actually very, very personally, because I've had one of my most famous cases that I share with medical students every year. It is a classical one, and it struck me so hard. And this is what's happening in Sudbury. I had a little old guy who was about, 85, let's say, went into hospital for heart failure. Incidentally found while he was there, he had foreskin infection, and it was actually not, the foreskin couldn't retract because of all the infection. So he was there so a cardiologist was taking care of him. Of course, he had nurses around him. Family physician was the most responsible physician. That's right, because he was one of my colleagues. So the family physician was alerted to the issue. Perfect. Identified the urologist, said, hey, urologist, could you please assess the patient? The urologist said, perfect. He's going to need a circumcision. Explained it to the patient. Great. Patient signed a consent form. Great. Urologist didn't have the OR time, so went on to a surgeon. General surgeon came in, did the circumcision. Happy as a little clam. Patient, his heart settled down, came back to see me 2 weeks later, which is pretty much the standard of care. So come back to your family physician 2 weeks after discharge. And I said, so, Mr. Tranche-Montagne, I said, I see here from the notes, I see what happened, blah, blah, blah. And, your heart's feeling better? Yes, absolutely. Perfect. Okay, great. Any other questions for me? He said, I do have one. I said, well, what's that, sir? He said, what they do down there? I said, excuse me? He said, well, what they do? I said, well, you had a circumcision. Is that what you mean? He goes, oh. I go, okay. He says, but it's gone. I said, yeah, they had to remove the foreskin. It was infected, and they had to just remove that part so that there wouldn't be any issues. Oh, okay. Is it going to grow back? He said. I said, no. And I, let me tell you, I've never wanted to learn how to knit so much as I wanted to that day, because I just wanted to make him a little toque for his little wiener, I tell you. But yeah, he didn't have no idea what was going on. I said, no, sweetheart, it's not going to grow back. I'm really sorry. And he goes, okay, well, how am I going to protect it then? So then we had a long discussion about the fact that removing foreskin is it's not a huge deal, and that, it didn't really need protection per se. But he had a major part of his anatomy changed after 85 years and had no idea what had happened to him. He had gone through 3 different providers that were actively involved in his care, and never mind all the nurses and alternative health workers that were all there. And not one person made 100% sure that he understood what was going on. Does he have responsibility to not sign a consent form if he doesn't understand? Sure. But you know what? These patients are vulnerable. This is a vulnerable population who should not have the extra burden of responsibility to make sure that the healthcare system is taking care of them. That is a failure on the part of the healthcare system. It is our responsibility to make sure that that happens. How do we do that? Well, we can make sure that there's a translator around. Let me tell you, I'm a Francophone. I have no idea, and I'm fairly certain that our hospital does not have any active translation for services for Francophones, even though we represent roughly 33% of the population in Sudbury. We just bring in a nurse or depend on a family member, but we don't have that service available. What else could be done? We could ask them to repeat it back to us. Can you repeat back to me what you understood, sir? Because I need to make sure that you understood. Okay. And then they would explain it back to you. Communication. Just yesterday, I saw a patient who had a part of her bowel removed. She had diverticulitis and had to have a bowel resection. So she came back to me 2 weeks after discharge. I said, how you doing? Doing great. Perfect. She says, yeah, I had a part of my bowel removed. I said, oh yeah. I said, I understood you had diverticulitis. She goes, I don't know. I said, what do you mean you don't know? She goes, I don't know what that means. I said, well, they removed a part of your colon. She goes, no, that I knew, but I don't really know why. She could have had a cancer. She could have had a ruptured appendix for all she knew. She could have had a massive abscess. She actually almost died. It was perforated and had no idea what her diagnosis was. So that takes up, when I talk about extra work to the Francophones, that took an extra half an hour of my time because I sat there with my computer and pulled up pictures of what the colon looks like and what part they removed. And then this is the diverticula, and then this diverticulitis when it gets inflamed, and this is what they removed. And this is a diverticulitis diet. This is a diverticulosis diet, and this is how this is what you need to watch for. I went through it all, and that was an Anglophone patient. So you can imagine how much misunderstandings occur with a Francophone patient. Communication. Right? How am I doing for time? I have like 2 more minutes, but I want to bring out one more example, because this one, I had a medical student a few years back who was a Francophile. I shouldn't say that. Francophone, but typical Northern Ontario Francophone. Had kind of lost a lot of the French and had some, was a little unsure of his French and kind of would rather speak English if he kind of get away with it. So I'm sure there was that bias felt by patients, kind of trying to bring them over to the Anglophone side. But he saw one of my patients. This patient had just had a rectal carcinoma and was sitting at the oncologist with his wife. His wife happened to be a nurse. This patient was fluently bilingual, had a little bit of a French accent, but really he lived his life in English. He was no problems with English, but saw the radiation oncologist. Sorry, And the radiation oncologist did what probably most of us are prone to do when we're in the presence of colleagues, and started speaking medical speak to the wife. And so she was explaining, well, sir, you have a stage 4 squamous cell carcinoma of the rectal verge. That'll be required, that we resected that and and your CEA is rising from 5 to 20, and we're going to be requiring some FOLFOX chemotherapy going forward, which could cause some emesis, And he's sitting there like the good little Francophone male that he is, because this is what they do. And they nod and smile, and they have no idea what's going on. And finally, his wife said, oh, excuse me, doctor, chérie, do you understand what she's saying? And the patient says, no. So the patient looked at the doctor and in all humility said, I'm sorry, could you speak my language? A little self-effacing, right? Meaning, can you please speak in an English that is not quite so medical speak so that I can understand? And she just looked at him pityingly and said, oh, I'm sorry, I don't speak French, and then kept speaking to the wife. He said to my medical student, I have never felt so small or inadequate in my life. That is not what a stage 4 cancer patient should be feeling when they are sitting in a cancer center fighting for their life. They should be feeling empowered. They should be feeling part of the team. They should be feeling that there are coaches and cheerleaders surrounding them, helping them every step of the way. And he did not. Communication. So this is why we do these sessions, guys. This is real life. This is not, oh, is this really important? It absolutely is, and it's happening every single day to our patients because we have some linguistic insensitivity that is rife within our healthcare system. Okay? So what we're hoping for today, is for you guys to be the change in the world, right? It sounds so trite, but, can we advocate for these key positions in the hospitals to be bilingual? Your triage nurse and emergency department. If there is a Francophone nurse on the floor and there's a bunch of Francophone patients, maybe we could put the Francophone patients close to each other so that that one nurse could be charged with all the people that are in that group. That does not happen. I advocate for it every time I'm on call. It does not happen. The Francophone patients are not linked to the Francophone nurses. And every time I go, I try again. It's not happening. Making sure that there's active offer to all patients. Ensuring that there is translation services available to patients, or at least booking more time if you know that there's going to be an issue, right? You can be the advocate. If you're a healthcare worker, but you see the physician speaking in English. Oh, I missed. Was somebody trying to say something? No, sorry. But if you see the physician speaking English to a Francophone and the Francophone's getting that glazed look in their eyes and doing the nod and smile, advocate. Sorry, doctor, could I maybe try translating? Can I help out? I'm not entirely sure that the patient understands. These are things that you can do. And again, just making sure that that information is available bilingually to all patients, making sure that you're aware of the services that are available. If you can be an Anglophone provider and still guide your surgical patient to one of the Francophone surgeons in town. That is a thing. I do it all the time. And let me tell you, the difference in their care is profound. And if you're not sure about overwhelming them, you can ask the patient, hey, you know what? This patient is Francophone, but they take a little bit longer to get into. Or this patient, this physician is Anglophone, but a little bit easier to get into. Which would you prefer? Ask. Okay. I think that's pretty good for time in terms of leaving time for questions. Any questions for us, guys? Or any comments? Examples of your family members, your people falling through the cracks?
Oh.
I see Sylvie Sylvestre, you've got your mute off. Is that because you want to speak, or is that just, oh, sorry.
Oh, I'm sorry, but I can speak.
That'd be great.
Okay, and I just reactivated my camera. Falling through the cracks, my father was hospitalized. At the time, he was 82. He's now 84. He was hospitalized for 6 days in cardiology. And at the time of his discharge on day 6, the geriatrician came to visit him, or us, I was there with him. And she said, so your dad has Lewy body dementia. And I'm like, what? And so for 6 days, it had been noted by several people that it appeared that he had Lewy body dementia, whereas he was French speaking and had received very little services in French. So she was able to assess, and in fact, it was a wrong diagnosis. That's it.
Wow. And you know, once we talk about, the more we talk about this, the more examples come up from family members, from friends, things that you've seen in the system. It always boggles my mind. You know, I've seen patients that are fluently bilingual, lived their life where their partner spoke English, so they lived their whole life in English. Their kids are unilingual Anglophone, and then they get a stroke or dementia, and they lose their second language, and all of a sudden, these bilingual individuals are now unilingual mother tongue. And if it's not recognized, again, right, this is about communication. We just happen to have a Francophone piece because we hit critical mass of roughly 33%. But if you have a Croatian patient, you know, don't assume it's word salad. See if you can get a Croatian translator and see if maybe this is their mother tongue coming out. Maybe they just lost their English. So important, right? I just want to do one little take-home message, and then if there's any other questions or comments, I would absolutely love to hear them. But I love this comment as a unifying kind of statement, which is cultural minority, linguistic minority Francophones are falling through the cracks and are feeling increased stress, perceiving decreased care, and avoiding health care as a consequence. But our awareness and our advocacy to promote the practice of active offer are essential to move forward. Kim, did you have a statement or a question?
Oui, premièrement, merci énormément, Megan et Tim, c'était super intéressant. For those who don't know me, I'm a Dean of Health Sciences at Collège Boréal. Active offer is something that we stress to our students, and I see there was a in the chat for other healthcare providers. And from the get-go, and you think that they chose Boréal because they want to offer services en français, and they do. But what we find, because we do surveys afterward of our grads in the workplace, because there is that additional workload, all of a sudden the active offer goes right through the window or in the garbage. And personally, as someone that is not shy to ask for my services en français, my son had to have surgery a few years ago. The nurse, a male nurse, had "Je parle français" on his tag. The first name of my son is Alain, not Alan, not Aline, Alain. And we're conversing with our son en français, and this nurse calls him Alain, but continues to speak in English. Why? And we kept saying, il parle français, on veut des services en français. So I think there's still a lot of work to be done. They start off with the best intentions, absolutely, in many of the cases. And Patrick, I'm sorry, now I just noticed I called you Tim, Patrick. Sorry. En tout cas, so, I mean, we are trying. And one thing I also want to add is it's very nice active offer, but I think we cannot forget to always reinstate, ask for your services. Again, like Sylvie's, my father was hospitalized a few years ago, and he's so scared to ask for services en français because it might be longer wait for him, or they're not going to like him because he's asking for a Francophone nurse. So I think la demande active also has to be part of this. Merci encore.
Merci, Kim. I would just like to echo, I had a similar experience with my son when he was very, very young, maybe 1, 2. We went to our family doctor. I was speaking in French to my son. Everything was in French. She came in, had never offered us services in French, never spoke to us in French, never made mention that she could speak French. And then when she saw I was speaking French to my son, she started asking him questions in French and then turned to me and talked in English. It's like, well, you're so close. You're right there. Just keep going with the French. But what I did want to mention before we go on to other questions, really the point of today was to sensitize people to the importance of the active offer, the importance of communication, the importance of French language services. If we can provide you with a couple examples of strategies that you can take forward, that's great. We're really happy to be able to do that, but we don't have time in an hour and a half to provide an actual training on active offer. And I just want to provide you with a couple resources. First, le réseau d'UME Francophone du Nord de l'Ontario prepared a phenomenal active offer training modules that are available in both French and English. It's 6 modules. It takes about 5 hours. And for those who are affiliated with either the Canadian College of Health and Leaders, the College of Family Physicians of Canada, or the Royal College of Physicians and Surgeons of Canada, you can receive credits for it. It has been accredited. That is a great resource. It'll talk a little bit about the stuff we went, but it'll give you more concrete examples of what you can do. There's also le Consortium National de Formation en Santé. And I'm sorry if you don't have time to take these links, note of these links right now, but we will give you the presentation later. They have a whole toolbox for the active offer. There's a lot of resources there, a lot of places you can go look to get resources and strategies for offering services in French. And finally, even NOSM's website has some pretty good information on it. A lot of it is links to the stuff that we've already presented, to the active offer training, to the toolbox, but they also have other tools like this MedInterpret, an interpretation guide, visual identification tools, Franco Doc, Google Translate. These are all tools that you can use. There's stuff available on each of those websites. I encourage those, if you're not sure where to start with the active offer, start with a few trainings, start with looking at some of these tools in these toolboxes, because those will be important tools for your toolbox.